I'm gonna start this debate by talking about a controversial subject here about why I believe that all or most interventions should be done in an outpatient center. I know my colleague, Dr. Venkatesh G, is going to come up here in a few minutes, and he's going to try and contradict everything I say, and we'll hopefully not throw too many rocks at each other. But this is what people say when you say, I want to do things in an outpatient lab. You say, well, you can't do that. Why not? Well, because I said so. And then you challenge that, and you say, well, I think that's probably a better place, and you get this kind of response, because that's why he said so. He's going to come up here in a few minutes, and he's going to tell me that everything I do is unethical, that I'm a greedy bastard, that I do unnecessary procedures, that I harm patients, that I cause higher amputation rates, and I cause higher mortality rates. How do I know that he's going to say that? Well, because he's already said this publicly in an editorial that he published in JAVT in 2021. In fact, he went on to say here that there's not one single quality study in atherectomy in 30 years. Not one single study. Well, personally, I find that rather insulting. I find that closed-minded because I happen to be the national PI for the EXCITE trial, which is a randomized trial for laser atherectomy for in-stent restenosis. So you're looking at an N of 1. So to say that not one single quality study says to me, that's an ignorant comment. It really is, because there's a lot of data out there after atherectomy, and I'm going to show you some of that. The other thing that he said is the only reason that atherectomy is done is because of the handsome reimbursement, basically implying that if I didn't get paid to do anything, I wouldn't do anything, and the only reason I do things is to get paid. Again, I don't think that's an accurate comment, and I'm going to show you why. We could talk about reimbursement for a long time, but I just have one slide here. This is reimbursement data on femoral popliteal stenting over the last 5 years. This is a CPT code. The payment system for inpatient hospital and ASCs is different. They use the hospital, the inpatient and outpatient payment system where there's a physician fee and a facility fee. The facility fee pays for all of the disposable items, the stents, etc. In an OBL, there's one global fee that pays for everything. So when I get paid in an OBL, with that money, I have to pay my staff, I have to pay my rent, I have to pay for my capital equipment, I have to buy my products, etc. And so comparing what a physician gets paid in a hospital is completely unfair, and apples to oranges is what you get paid in an OBL. But I want to point out that my reimbursement over the last 5 years for just putting a stent in an SFA has gone down 26%. Whereas the hospital reimbursement has increased by 18%. That's a delta of 44%. So because I just wake up every morning and I'm a good guy, I get paid 44% less now than when I got paid 4 years ago. So if you're going to accuse me of being greedy, that's absolutely not true. If I wanted to be greedy, I'd be doing other things. Believe me, not putting stents in SFAs. I want to talk about atherectomy for a few minutes because this has been highly controversial in the literature recently, and I want to know why we demonize physicians that use FDA-approved devices. Why have we made it a crime to treat claudicants? Imagine if a woman was denied treatment for stage 1 breast cancer because they're just not bad enough. Why don't you just go home and exercise, come back when you have stage 4 cancer? Why do academicians, and so there's a small group of them, publicly humiliate physicians that choose to work in outpatient settings? This is an expert of an essay that I published on LinkedIn a few years ago, and I said, I'm so tired of hearing there's no evidence for atherectomy. There's a mountain of evidence for the benefits of atherectomy. I don't have time to recapitulate it in crayon so that you can understand it, but I'm writing this slowly so you can keep up. Although I do appreciate it's hard to read when your head is buried in the sand. There's a new thing called Google. Try it. I'm sure you might find something. And that's how we're treating physicians right now. I think it's completely unfair and inappropriate. We're at an epidemic for PAD right now. The population is aging. Our risk factors are increasing. CLTI has a higher mortality rate than stage 4 cancer. It's a non-curable disease, and yet there are some that argue we do too many interventions. I would suggest that we don't do enough interventions. I think we need to do more interventions. When you look at this data over the last 15 years, as we've done more endovascular procedures, as we've done less open surgical bypass, our amputation rates have steadily gone down. I wanted to look at my own data. This is my own data. Maybe I'm a greedy bastard. So I said, well, let's look at myself. How can I stand up here and defend anybody else? So these are my Last full 2 years that I worked in a hospital, these are my numbers, and my first 2 full years that I worked in an OBL. At the bottom, you'll see the number of cases I did. The number of cases I did in OBL went down. If I was a greedy bastard and I was doing unnecessary procedures, those numbers should have gone up. I should have been scheduling more patients, have them come back every other day and just inflate a balloon just to get paid. If you look at my stent use probably in 2014, 83% is probably a little too high. I was probably putting in a little too many full metal jackets at that time. As drug-coated balloons came on the market at that time, we started adopting a strategy of leave nothing behind. My stent use kind of slowly went down. My atherectomy use, as we were vessel prepping and so forth, is kind of slowly go up. But if you look at my last year in a hospital, my atherectomy use was 20%. My first year in OBL was 29%. My colleague wants you to believe that my in-hospital use atherectomy use was 5%, and when I went to the OBL, it was 95%, just to make money. That's absolutely not true. And my numbers, data is in line with the OEIS registry, which is a national database of over 150,000 procedures where the atherectomy use in OBLs and outpatient labs is about 30 to 40%. But this is probably the biggest data that we can talk about. This is a project now that's been going on for about a year. It's been spearheaded by Jeff Carr, Ralph Langhoff, and Eric Sosemski. They went through the literature for the past 30 years and have extracted all of the data for atherectomy for all the naysayers that say there is no data for atherectomy. So they've come up with 327 papers that have been published in the literature. This has been presented at AMP, it's been presented at Viva, it's been presented at Link, and now there's a manuscript that's going to be submitted in the next month or so. There's about 50 slides in this deck. I don't have time to go through them all, but there's outcomes data and so forth. I just want to point out a couple slides. In 130,000 patients treated with atherectomy, there's 19 randomized control trials. That's far more than 0, and more than the one that I participated in. There's 11 papers that are meta-analysis, and when you compare this observational data and randomized data, this falls in line with other subspecialties. When you're looking at biomimetic stents, coronary DES, CABG, carotid arteries, the majority of the published research is observational. And what you see with atherectomy is a similar pattern of randomized trials versus observational trials. I'm just going to show a couple data sets on one thing. This is on vessel prep. I know this is a controversial topic, but this is just extracting this data on vessel prep and comparing atherectomy to PTA for above-the-knee lesions. There's an increase in primary patency rate, there's a decrease in major amputation rate, and there's decreased bailout stenting. For below the knee, you get the same thing. Decreased CDTLR, decreased major amputation rates when you use atherectomy as a vessel prep tool. And then this paper was just published about 4 weeks ago by Eric Sosemski's group out of the Brigham. This is variations in revascularization strategies for CLTI patients. This is the Medicare beneficiaries database, a large group of patients, almost 200,000 patients extracted, patients that presented with CLTI, whether they had endovascular treatment or surgical treatment at inpatient centers and outpatient centers, 1,800 facilities. So this is a rather large, robust data set. What it showed was there's a tremendous variation about how you're going to be treated depending on where you show up. About 77% of the time, people are treated endovascularly. About 22% of the time, people are treated surgically. And if you look at the outcomes, in endovascular treatment, there's a statistically significantly lower rate of major reamputation at a cost of repeat procedures. There's a statistically higher incidence of major amputation if you're treated with surgical bypass with lower repeat procedures, perhaps because there's fewer limbs to repeat on. If you abstract that for atherectomy data only, there's a lower rate of amputation at institutions that provided a higher rate of atherectomy. And so again, my colleague and I can stand up here and throw stones at each other all day. He's going to show a study that shows atherectomy is terrible. I'm going to show a study that shows atherectomy is great, and we're going to go back and forth all day. But the bottom line of this paper says that places that have endovascular procedures, the higher volume centers have better results than lower volume centers. That seems intuitively obvious. If you practice the piano, you're going to be a lot better piano player than if you just play chopsticks once every year, okay? So why are we demonizing physicians that are doing high volume work? Because they're better at it? because I would argue that the papers that have negative outcomes are probably in low-volume operators. So all that aside, I'm going to talk for a second about why I went to an OBL. Why did I go to an outpatient facility? This is 100% of the reason. It doesn't matter what I get paid. I don't care if I did it for free for charity. But I'm going to ask you, what is the difference between a complex multi-billion cell organism versus a single cell amoeba? What's the similarities? It's the primal desire to avoid noxious stimuli, okay? And in my opinion, hospital administrators are a noxious stimuli, all right? There is, since the 1990s, when university programs began offering graduate level degrees in hospital administration, we as physicians have given up the boat, okay? There has been a roughly doubling of the physicians in the last 50 years. There's been a 3,000% increase in the number of hospital administrators in that time period. We have allowed them to hijack our system. We have allowed C and D level students that are not capable of getting into medical school now work side by side with us and tell us how to do things. That's the reality of it. And if you go back to the CPT code I showed you, hospitals get paid 3 times more to do this in a hospital setting than what I do in an OBL. They are the ones that are raping the system. The hospitals are the ones that are raping the system to pay for all their administrators who are basically worthless, in my opinion. So what are the benefits of an OBL? Patient satisfaction. Orders of magnitude, patient satisfaction scores are higher. Much easier for patients to navigate. Rather than this endless cattle call maze of hurry up and wait when they show up in a hospital, they pull up my front door and they walk right in. Much more efficient. Immeasurable by orders of magnitude. I had a choice in what my capital equipment was. I got to choose what cath lab equipment, what ultrasound equipment, et cetera, that I use. I wasn't told what I had to use because somebody else told me that's how it's going to be. Supplies. If I want a particular widget, I tell my office manager, order this, and it's usually there in a short period of time. I don't have to go to a VAC committee and explain to a dermatologist, a urologist, and a psychiatrist why I need the latest and greatest widgets out there. The personnel that I have are handpicked. They're people that I interviewed, people that I think are the best of the best, and they are. When I go to the hospital now, I work with travelers who don't know what the hell a sheath is. They don't even know what to do. I just had a patient the other day that had a heparin allergy, and they put heparin flush in all the bags before we started, and I had to break down the case and start all over because they don't know what they're doing in the hospitals anymore. We participate in clinical research. It's markedly more cost effective. The burden to the payers is 40% less to do the exact same procedure in a hospital, or in my office, than it is in a hospital, and yet they still can't balance their budget because of all the noxious stimuli they're paying 6, 7, and 8-figure salaries to. Billions of dollars could be saved to the healthcare system if everything was moved out of a hospital. Let's talk about during COVID, during the plague. I remained open every day. I never closed my doors once, because we're not regulated by the idiocracy of hospital administration. We continue to perform limb salvage procedures every day when hospitals were just cutting off legs and wouldn't even let people in the door. In an outpatient lab, it puts the physician back in the center of healthcare. It allows me to make decisions about healthcare. It allows me to control education, everything about the patient experience. I'm in control of that. As a hospital employee, you have no more value to the hospital than the guy pushing the broom down the floor or the lady serving lunch in the cafeteria because you've been tossed aside. That's exactly how it is. So in conclusion, the criticism of atherectomy is biased and unjustified. Atherectomy is a valuable tool to treat PAD. All devices can be associated with adverse events. The scalpel is a device. Atherosclerosis is a progressive recurrent disease that is a worse prognosis than cancer in patients with CLTI, and yet we don't blame the oncologist when a patient with stage 4 cancer dies. There's a strong growing trend for endovascular procedures to be done in an outpatient setting. These procedures can be done safely in an environment, even complex CLI cases, but I believe that this is critically important. I didn't have a lot of time to talk about it more, but operators should practice at their level of experience. If you're not capable of putting in a stent in a hospital, you should not be doing it in an outpatient environment. Not a question in my mind. You have to perform at your level of capability. But compared to a hospital, patient satisfaction rates are significantly lower or significantly higher, and healthcare costs are markedly lower. And so I'll leave you with this quote because I think this ties into the live case we're just talking about. It's easy to be a hero and do a lot of dilatations. If you want to be a hero, you better be a hero in the follow-up also. That's Andreas Grunzig, the father of angioplasty. Thank you very much for your attention.